Saad bhai, we need something on this so the laptop doesn't fall. Yeah, I have done that many times.
Once today, before,
So,
before the end of the day, you'll have something.
Okay.
When you have a task plan,
We need, because it's slippery.
don't worry.
Okay.
I actually did it purposely for you.
To drop the laptop? Okay. I see. This is not the first time that would have happened. I have dropped the laptop, and I dropped it, and that laptop still works. By the way,
That laptop.
it still works. That, and I was
Really scary.
I was
That's what we Pakistanis do.
I was trying to tell Kambis that, oh, one time I dropped the laptop, and I dropped it right there this morning, and this is how I dropped it. Anyway, Assalamu alaikum. So Kambis gave a quite extensive talk. My presentation is going to be very focused, like practical tips. Okay. For radial and linear, he already explained the difference. Just you all do a regular scopes. You EGG or OGG scope, chronoscope. You're looking forward, you're moving. ERCP scope, you're looking at the ceiling and moving forward because it's a side. Okay. EUS scope, you are looking where the wall and the ceiling meet. So just remember, that's the basic concept. Because when you get to the pylorus of whichever structure you are looking at, so that needs to be in mind, where the camera is and where the transducer is. On EUS scope, wherever your camera is, your transducer is 1.5 centimeter to 2 centimeters beyond. So if you're at the ampulla, you put your scope on and your camera point on there, your transducer is not at that. It's beyond that. And that is like for any structure, wherever your camera is, your transducer is not. Okay. It is always going to be beyond that, so remember that you have to pull it back. Okay. And we were talking about for the radial one, you always need a balloon because you need a fluid medium around that. For linear, you don't need it. And they were asking me, I personally always use it. The reason for that is there could be bubbles in the intestine, and especially if there's a diverticulum in the second part of the duodenum, or you're not able to approximate your transducer against the wall, opposed up against that wall. What I do is I put fluid in the balloon. So that gives me a space to have a position. So that's my personal preference, but you don't have to use the balloon with the linear, okay? That's one. I think Kambi's already explained about anechoic, hyperechoic. Blood, when it's flowing, it looks pitch black. Clotted blood is white. So that's all. So if there's a blood in there, like it's clotted, like whenever you see a thrombus, that's never going to be black. You're going to see white stuff in the rest. So that's the difference between the clotted blood and moving blood. Other difference, other thing, peritoneal mass for any reason, like mass cancer all look hypertrophic. Peritoneal mass look hypertrophic. So that's another difference. It is a fat component to that because of the mesentery in there. Okay. So this is what I really want you guys to pay attention to. I'll start that in a minute. Whenever you move through the GI tract, your transducer, when you're moving through the esophagus, moving straight, your scope goes into the stomach, it's taking a different angle. It's going into the duodenal bulb, you're resting on the greater curvature, looking like that. You go to the second part of the duodenum, you shorten the scope, transducer flips, and looking at downwards. So one organ you may be looking at different places, and it completely changes the shape. Your orientation is going to be completely keep changing all the time. So that's you have to keep in mind. So if you are looking at the pancreas from the stomach, So it's sitting like that. When you go to the D2 or D1, it's gonna flip. So that's also, I'll show you a couple of images to tell you what I mean by that. So here, so this is going from the esophagus into the stomach. Pay attention like where the ultrasonic rays are coming and how they are changing the position while you are moving your skull. See that? Right there, linear scope. You see that those ultrasonic waves coming. Scope moves, things keep changing. So every time it's a different orientation. So this is what happens. We talk all the time about these stations. This is station 1, station 2, 3. I don't even remember honestly what those stations are. For me, station is esophagus, stomach, and duodenum. These are the 3 stations. So I need to remember in what portion of duodenum I am and what I'm gonna see. So make your own stations, but remember that. Follow every station every single time. Okay, so you don't miss any. So from stomach you can see so many structures, from duodenum you can see so many structures, from esophagus you see mediastinum and all those structures. And what I do is, if it's a patient is like critically ill and we need to get to the bottom of it, I will go to the area of problem. But if it's a pancreas head mass, I will go straight to the duodenum. But if I have opportunity to spend more time, which is 90% of the time, more than 90% of the time. So I always start at one place, which is always the same place I start, and same pattern I follow all the way, and same pattern I finish. But if it's a critical ill patient, go to the problem, get the diagnosis. If it gives you time, gives you opportunity, do the same thing. Right? Start from the what you're used to, so you don't miss it. Like make it a habit. It's driving a bicycle. Same thing, over and over, over and over. So make that happen. Okay. So I don't care how you call those stations, but I will tell you what I do, and that's how I teach, and that's how I ask my fellows to follow. For me, it always starts right below the GP junction. First, celiac artery, SMA, aorta. That's where it starts from. So I'll do the stomach, go to the duodenum valve, do a second part of the duodenum. I do the mediastinum on the way back. So they always follow the same pattern over and over and over. Okay? Now look at this. So here it's coming down. Transducer right there. You see how it's changing the position? It goes up and down, and look at the structure. Earlier, that transducer was like this. Now it's like this. So every time the position is gonna change. So just keep that in mind. Like it's not gonna be any place you are, it's not gonna be same place, same orientation. Every time you get disoriented, which is gonna happen hundreds of times, okay? Go back to the familiar station, start over. Don't try to interpret yourself what it could be. You need to have your anatomical structures to interpret where you are, okay? And now going, earlier you saw it was going like this and looking at the head area like that, and now it's looking from the bottom up. Okay, so whenever you see look at the pancreas from duodenal valve, that's going to be different orientation. When you look at the pancreas from T2, it's going to be different orientation. When you look at the pancreas from stomach, it's going to be different orientation. Okay? I put those stations there which are in the books, but I don't follow those stations. Okay? We'll go through these things during live cases. Other thing is, for EUS and for really good exams, and that's true for any endoscopic exam, you need to be comfortable. You should not be nervous, and patient should be comfortable. Most importantly, scope should be comfortable. Then it's gonna follow your commands. If the scope is in stress and you have turned it like this and your body is twisted, it's never gonna happen. So everybody needs to be in a comfortable position to really do a good exam. I'll come to this in a little bit.
I think it's important in almost every endoscopic procedure.
It's
Because you need to have you need to start thinking about your back and neck at a young age when you start, not when you reach my age, because by this time it's too late. We are very excited when we're doing procedures and forget about your own well-being. And I think that's important. It's being taught now at our time, nobody actually told us as well. But I think it's very important, especially young people. Make sure that your table is the right, especially longer procedures for all issues.
and we're doing more and more and more endoscopy. And this is what our life is. This is what our business is. This is what our profession is. If you don't take care of your own body, and you will get retired very early, at very early age. So I don't think you want to do that. Look here. This is like, we all have seen these atlases, right? Everybody has that. And you have seen this image, I'm sure, somewhere, right? And when you are, so here, this is the stomach, pancreas kind of behind, this is the back, right kidney, left kidney. You can see the spleen there. So this is a normal, right? And this is what you see in the atlas. Now, and this is when you are in the stomach, this is the image you see, right? From the pancreas, like when you're looking, your transducer is going like this through that. I'll show you that again one more time. We'll go over the previous images. So this is the image you get. You know, if you have this, take this paper out of the atlas, flip it over, look through the light, that's your EUS image from the stomach. Okay, like when you are in the stomach, you see the left pancreas, right? Then you rotate the scope to anti-clockwise. You see the body, tail of the pancreas. You see the left kidney, tail is tucked between the spleen and the kidney. That's the image you're gonna get. So if you really need to get this image in your head, just take a look at that, this page from the atlas and flip it over. Okay. Now going back, I want you guys to see these images one more time, and then I'm going to show you the normal exam. Okay, just pay attention to that, where the transducer is. Into the stomach, looking at the pancreas, clockwise and anti-clockwise. Okay? And we'll show that movements during the, like when we do the actual exam. Next one. Moving down. This is a linear scope. Radial is different. Radial gives you a straight image, and that's like a CT scan image. I want, take a look at these three, and then I will show you a complete EUS examination. Okay. So here, this is what we call a station 1, 2, 3 in the books, but this is only one station. You can also make it like, okay, stomach is one station for me because I don't move it from that. D1 is a one station for me, draw them both. D2 is another station for me, and esophagus is the fourth station. So basically, there are really 4 stations. Okay. And look at that, how everything flips like when you're coming back. So every time it's going to be a different image, especially when you're moving back from the D2 or D3 into the stomach. Okay. So now, I think we can go over those. Kambi's kind of went over those already. So here, as I mentioned earlier, for me, the first station is right below the GE junction. The first structure, which artery do you usually see? The celiac, right? And which coming off the aorta. So the goal is to find the aorta. What is the first branch of aorta below the diaphragm? It's not right? Okay. 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 And here, so what I do is like get the scope to the GE junction, go below the GE junction, inflate the stomach. Even though air is not a friend, but you need to know exactly where you are. Okay. Inflate the stomach, go towards the opposite wall of the stomach, like towards the greater curvature. Okay. Suction. Then when you are there, this is going to be probably 7 to 8 centimeter below the GE junction. You suction it. Okay. We'll demonstrate all this. This is going to be over and over and when we go through the cases. Suction it, big wheel towards you, rotate the scope. Scope is going to be in the neutral position, lying like this for you. Okay. I think we can do one, show one example.
That's the plan.
That's the plan.
Your patients are ready.
Okay.
So you can actually show all these live as well.
Okay, let's do that. But I can go through this quickly. It's a minute and a half. So went to the upper side, big wheel towards you. That takes you to the left lobe of the liver. Rotate the scope to the right, and you get to the aorta. You see the aorta right there, and celiac coming off, and then celiac dividing into 3 branches, which are left gastric, common hepatic, and splenic. You follow the splenic, that takes you to the pancreas, body of the pancreas. Right there, body of the pancreas, clockwise rotation, takes you towards the distal pancreas, distal body. When you see these 2 structures right there, that's one of them is a splenic artery, other is a splenic vein. Splenic vein is always at the bottom. It kind of makes the bed of the pancreas. And then from there, sometimes you can see even a left renal vein as well. You see, if you follow the splenic vein towards the neck area, this is that Kambi was talking about the portal vein confluence. I'm going to stop there just for 1 second. Actually, this is important right here. So this is in the stomach, okay? We're still in the stomach. Splenic vein, superior mesenteric vein, making a portal vein. Portal vein is going towards the liver right here. Okay. Bile is going to be underneath right there. What's happening? ये क्या हुआ इसका? 2 क्यों हो गए?
Can you press it again? What do you want to do?
1 मिनट. Okay.
Can we
So
talking about this area?
you saw the portal vein right here, right? That's going towards the liver. Just consider that you're sitting in the stomach, looking from top down, okay? So your pancreas is here, your neck is here, head of the pancreas is right somewhere there, tail is on the other side, liver is here, portal vein there, bile duct is going to be somewhere there, okay? So just remember that, this whole, okay? And see how that's going to change when you are in duodenal valve. So right there, when you get to the duodenal bulb, take a look at duodenal apex, that upper corner of the duodenal apex here. I'm gonna okay. So the bile duct, in the stomach when you were looking at it, pancreas, you saw the pancreas, you saw the portal vein, bile duct was all the way this way. In duodenal bulb, first I remember I saw said like you're just imagine you're looking at those structures from top down. Okay, you get into the duodenal bulb, your scope is resting, getting into a long position, resting on the greater curvature of the stomach. Your transducer, when it gets to the duodenal bulb, it's like this. Okay. So now we're looking at those structures from the bottom up. That's why everything flips. Now the bile duct is closest to the transducer, portal vein, pancreas. Make sense? Very important. Because that's why I was showing those cartoons that how it's gonna change. So here now, I'll show you the head is gonna kind of come, this is the bile duct, portal vein. Head is gonna be right here. Your neck is gonna come around this. Tail of the pancreas is here, not on the other side. Okay, very important. Everything flipped. So this is the most important concept people don't get. Okay. So right here, head, neck, tail is like that. The pancreas is like this. Okay. Bile duct there, portal vein. I'll show you in just a second. Pancreatic duct right here. Pancreatic duct is going to go like this, come here into the neck right there, and then going to go like that. So I'll show that all in the live case. What I do. And then you go to the D2. You're looking for basically, there are two ways to do it. When you get to the ampulla, you can take a look at the ampulla. Put your camera right on the ampulla. What did I mention earlier? Your transducer is like beyond that. So you have to pull that back scope to really look at the ampulla and the knob. Okay? So once you see that, either that's one way to do it. Other way is you can take a look at that. You find that aorta. Aorta is going to be a tubular structure. There are two things on the left side of the aorta, two things on the right side of the aorta. Aorta is in the center. IVC and then right kidney. When you go to the right from there, bile duct, pancreatic duct, uncinate process right. So I'll show that all in the lab cases. Okay. So I think these are the main practical tips. We will talk more when we are doing the live cases. आप अभी बात करोगे या बाद? You later? Are the cases ready? Okay. So what we can do is I'll show one case, complete case, and then we'll do hands-on. I'll show how to do that, how the hand movement is, how to hold the scope, how you have to be comfortable, patient needs to be comfortable, the scope needs to be comfortable, and we'll show them. Okay. Any questions right now? I know it was very clear, no question here. Anything you may have, I think that may get a better answers during the cases anyway. And but if there's any question I can answer right now,